But I think the big point is that there's a lot of depression and anxiety there, and there's a lot of potential to use a lot of people are not using the internet with moderate to severe, but indicating they would, at least websites and things like that. So there's a huge potential there. So what's missing? There's a real opportunity there. There's lots of people with anxiety and depression. They're not really using the internet. 48% are saying rarely, if ever. And yet we ask them, would you? They say they would, right? So this is where that little study was just a little idea to say, okay, let's get the sense of that. And if we think about the internet and web surveys as a surveillance tool where kids do a survey like that, but as part of their curriculum. So a lot of my research is in high schools where we can get the schools to sit every kid down and they sit in the computer lab and do a survey, right? Health survey. So that notion of surveillance, where people could get flagged and get information, do the PHQ and some other things as sort of a mental health module, and say, oh, it looks like you might be depressed, and get that tailored feedback in, I think is a huge issue. I mean, a huge opportunity. So where my enthusiasm comes from, sort of this approach, is I'm doing a survey of about 3,000 youth. We're on wave 7. We survey them every 6 months. It's a cohort study. And we get about 1,500 or 1,600 people. I think we had 1,700 or 1,800 one way. And they don't taper off. Some we lose for one wave and then come back for the other. It's kind of an interesting phenomenon. But these are high school kids. And what we found is it works really well. We've built that relationship over time. They do the survey. We use text messaging reminders, Facebook reminders, in-school reminders. The other thing we've got from that is the schools really like it because they don't have to do anything. They just take their kids into the computer lab. They go in, they can either click a box on our survey and they just put in their email and then we'll email them their their login for the web survey. So we've learned that schools really like that notion that they're really concerned about their students' use of substances in this case, and mental health, and we're doing a lot of depression and substance use like marijuana, alcohol, and other drug use, binge drinking. So schools think it's great because they don't have to do much. They take people into the thing, and we can start. We're saying this is the first step to deliver feedback information relevant to where they are. So what we've started doing in there is we have messages about smoking and breast cancer, and we've developed tailored ones. So the girls have pictures about girls and stuff like that. And if they're a smoker or non-smoker, they get a different message. So we know when they start the survey, their demographics and where they are, and they get one type of message. Our First Nations students, we had First Nations focus groups, and we just they ended up taking just a feather and putting a semi-transparent image of it at the bottom of the standard image. And those students said, no, I recognize I don't see it as a token. I see it as respecting me and something I should listen to. So it's a way of saying if we know some of our students, when we ask them demographics, either in a previous survey or in that survey, that they're First Nations and a non-smoker, we can serve them up a certain type of message that's relevant to them. So that's worked really well. The other thing we've done with that story is we've embedded RCTs. So we've randomly assigned some people to get a standard or a control message. We've done it at the school level because we're worried about contamination. But the approach makes it very easy to do that. You just use a wait list, and then we did a crossover 6 months later. The other thing we've learned is the longitudinal assessment. If you've built that relationship and engagement, so we do Facebook polls and stuff like that to build the engagement, you can get that longitudinal data on outcomes. So if you're referring something, so one of our RCTs, we referred people to quitnow.bc. Another one is the smoking message, smoking and breast cancer. But you can follow up over time and see how the kids are doing. So if you're referring kids to a counselor or referring them to Mood Gym or something like that, you can see, is that working for you? So you can build in that program evaluation, right? The other thing, it's not very expensive. So LaDanne did the Douglas College one, it's fluid survey. She's not a computer programmer, she's very good at her job, but it wasn't like a huge thousands of dollars or hundreds of thousands of dollars. And same with this big BCU survey. We give a $25 incentive, but we've got quite a few schools doing it in school as part of their drug and alcohol programming. So schools could do it and wouldn't require that incentive. And the person doing it could do it all out of Vancouver and have surveys tailored to each school, could have a few custom set of questions. But people in Prince George would get the tailored feedback to the mental health resources in Prince George or smoking cessation or whatnot. So it's huge potential there. So given that I can do that with this high school survey, why aren't we doing that at Douglas College, right? So that gets me to the next steps. If we can somehow set up a system where the students feel comfortable and it's the way we've marketed and engaged with our students that this is a service, that they can come in and do a mental health screening. It could be part of a career planning module or whatever it might be, so they see some benefit to it, or get credits in a class or whatever. We could screen them for depression, anxiety, all sorts of things. Include referrals both to services online and in the community. I think the trick is, I was originally going to title this presentation, we need to closing the loop or something like that, because we can send people, do surveillance, and then send them to online resources, which is very cost effective and easy to organize. But I think you've got to watch, if you're sending someone to a certain depression resource, the trick is having a system in place where if they need help, they can connect with the school counselor and have that counselor or the local GP or whatever might be aware of those referrals being made and what resources they're getting. So the next step is to start figuring out how to do that. In BC, we have MindCheck. So it's a little screening. So if you go to mindcheck.ca, there's mood and stress. So basically, they put kids through the PHQ, the GAD, and there's a stress one. And then if you screen high, there's information about depression, information about anxiety, and there's also links to the kid's help phone. There's hints on how to manage your depression, how to manage your anxiety. It's all funded. So the great thing about this intervention, if I could work with them and say, I'm going to drive traffic to your website from students at Douglas College or UBC or the local high school, just give them the heads up. And then the counselors at the college or at the high school say, okay, we're going to be pushing kids through this programming that outlines these strategies for dealing with help. So everyone's on the same page. It's sort of win-win. These guys are happy because they're getting traffic through their website. The counselors have a tool at the local high school at Douglas College saying, oh, did you go to the MindCheck? Did you work through the exercise? How did you do? They can get a sense of when they need to refer on to a primary care or a psychiatry program, right? And it's not that expensive because the services are all there. It's just a way of coordinating and setting up those referral pathways. And that's, I think, where the idea of bringing in surveillance, which is what we do in epidemiology, instead of doing a big epi survey and then putting the data together and a year later publishing a report or 4 years later publishing a report, which might get read by someone at the school board who decides to do a depression intervention, we almost bring in the intervention. I think it has to be more around health literacy. I think that's the big one. So we might not have yet the clinical tools, although Mood Gym is something, those programs are very promising. At the very least, what we could do is mental health literacy. These are the things to watch for. And if you start having these problems, these are the resources where you are that we could refer to, whether it's a school counselor or some sort of primary care or psychiatry outreach program. And they could be tailored to wherever the kid is. The thing is, we could tailor it to kids who are Punjabi, kids who are Chinese, kids who are Caucasian, very easily, kids who are First Nations, and drive them to the resources that are appropriate for them and teach them the warning signs for depression, anxiety, managing stress. And I think that, for me, is the exciting thing, that these pieces are all there, and it's using the internet to direct people to the right resources, to get the right person when they need the help at the right time and guide them to the right place.